So for the Q&A, we'll have Professor Sakura, myself, and Justin, if you're still around. Yeah, Christine is there. So.
Okay, so so far we have a few questions for Professor Kamaka. So a few attendees are quite interested in comparing vertebral block versus other blocks, for example, erector spinae block, and also serratus anterior block for analgesia, and also anesthesia for breast surgeries. So what are your thoughts on those blocks, Professor Kamaka?
Okay, let me first address the question about serratus plane block or the. Now, if you're using it for analgesia, I think the evidence randomized studies will say that yes, it provides effective analgesia after breast surgery. Today, there is not much literature on long-term outcomes with relation to some of these serratus plane blocks and the PEX blocks, etc. Now, when comparing to ESP for surgical anesthesia, I have to say there are some publications as case reports, and more recently, I have also been witness to a publication describing it in conjunction with sedation. I think given that a technique, we still don't know much about its mechanism of action. I think as a researcher, I would say, and with a track record of experience in this field for over 2 decades, I think it is hard to believe that an ESP block with conjunction with sedation will provide surgical anesthesia for primary breast cancer surgery when we have been struggling with the use of multi-level paravertebral blocks for so long. But nevertheless, there is more research to be done in this area, and very soon you will be able to preview many of the work that will be described in relation to some of the perispinal injections and how an ESP plane block actually produces its mechanism of action in relation to anesthesia or analgesia. This is all I may say at this very moment. But if you ask me, would I do an ESP block for surgical anesthesia? The answer is no, never. Thank you.
Okay, so thank you, Professor Kamaka. The other question is also directed to you. So it is from Dr. Sammy L.B. Marksand. So how much time do you need to do all those 6 injections plus for the paravertebral block plus the pectoral injection? And are the surgeons actually happy for the time that you spent on these blocks?
Yeah, I think that's a very good question, and I think it's very valid. We do them in a procedure room, which is adjacent to our operating room. So these procedures start more than half an hour to an hour before the end of the ongoing surgery. So as I mentioned, we do multi-level injections, 3 injections, T2, T4, T6, with 7 to 8 mils of local anesthetic with added epinephrine. Somebody asked the question, how much epinephrine do you add? We use it in a concentration of 1 in 200,000. This is not to increase the duration. It is to increase or reduce the systemic absorption of the drug. And those of you who are interested can look up our paper in anesthesiology many years ago, demonstrating that paravertebral injection is like giving a drug IV. Your peak concentrations that develop after a paravertebral injection is just like a simulated injection of an IV infusion. By giving epinephrine, you can reduce the systemic absorption, particularly the early systemic absorption, and thereby potential for toxicity, especially with multi-level injections when you are performing multiple injections with large volumes. Multiple injections mean multiple chances of vascular injection, which, as I mentioned, if you inject saline as a test bolus, you can almost exclude it. I haven't actually seen, touch wood, an intravascular injection in more than a decade now of use of ultrasound with ultrasound guided, even with paravertebrals. Next is The epinephrine may act as an intravascular marker, which again, if you don't inject intravascular mark, then you don't need it. So this is how I would address it. Now, do the surgeons agree to that? I think it has to be a team-based effort. If you just do it occasionally and you do it without much planning, then I think it'll never be popular. It has to be introduced slowly and introduced over a period of time. Today, we have more than 2 decades of experience with our surgeons, so much so that it is never even questioned whether we are going to do a multi-level injection paravertebral block, as long as when they perform the surgery, they are able to complete the surgery effectively without patients complaining later on what was done and so on and so forth. They see the beneficial effects after surgery when, in fact, in the PACU, they are almost awake, alert, pain-free. And once they go back to the ward, they are eating, drinking. And with, as I mentioned, we don't put any catheters anymore. They get oral non-steroidal analgesics with paracetamol and any antiemetics if required. So etrocoxib is our go-to for most of these in the post-operative period with the paracetamol, and even if required, some tramadol as a rescue post-operatively, but very rarely it is required. And this together has helped us immensely in fast-tracking many of these patients through our operating room with a very expedited recovery in some cases.
Okay. So another question concerning breast surgery, so is from an anonymous attendee. So when primary breast cancer surgery is simultaneously performed with breast free flap reconstruction surgery, so how does the paravertebral block affect the blood flow to the flap anastomosis? And also, can a lower thoracic paravertebral block spread caudal to cover the lumbar area of the flap side as well?
Yes, I think that's a very good question. Paravertebral block itself has been shown to improve blood flow to flaps many, many years ago. There are some literature relating to that because of its ipsilateral sympathetic blocking effects. And if you look at the sympathetic supply to these areas, they're often from the lower thoracic dermatomes, or from where these sympathetic supplies come. So if you perform a paravertebral block, yes, it will improve the blood supply to these areas and can be an added benefit of performing paravertebral, not only for analgesia, but also for the sympathetic effects. Similarly particularly if you do latissimus dorsi flaps, etc., this can be beneficial. But when I do tram flaps are more extensive, involving the abdomen and an incision that is very long. I usually do epidurals in these patients because positioning them post-operatively is also very important, and the surgical positioning that they maintain to reduce any tension on these abdominal muscle flaps are an integral part of their management. So if you have a patient who is in a lot of pain or having a lot of nausea, vomiting, it's not desirable. So I find, but for when it's say a tram flap, I do epidurals, and surely with it you will have increased blood supply, blood flow, etc. But also for the other traps flaps like the latissimus dorsi flaps, paravertebral blocks can be a good choice.
So thank you, Professor Kamaka. The other question will be directed to Professor Sakura. So in your opinion, so you have talked about many blocks for concerning knee replacement. So in your opinion, what would be the best block to give as analgesia for this operation?
You mean when it comes to pain relief only? So you can give femoral block when you think about the quality of analgesia, I mean intensity of analgesia, but in today's environment, I think you should at least conduct a single adductor canal block. If you can conduct, if you can use a catheter, you can insert a catheter to give continuous infusion after bolus ductal canal block. And femoral triangle block. And if you can add IPEC block. So my first choice is always continuous ductal canal block, femoral triangle block, and IPEC.
May I just interrupt here for a moment? I have a question for Sakura-san here.
Mm-hmm.
You describe all these different techniques and the tibial nerve blocking potential of the IPAC. You do not allude to the fact of this popliteal plexus block that also innervates most of the posterior capsule, and being a periarterial injection, it's a very simple technique and just more or less a lower extension of the adductor canal block. Any comments on that?
You mean I haven't tried that technique by myself, so I cannot say for sure. I can say what difference they have between the two. But I think IPAC block, when it's done at the very distal level, there's a little chance, very little chance of getting sciatic nerve block after surgery. So that and the blocks the other groups proposing is a little bit deep block, I think. I've never tried, maybe someone help me suggest,
Yeah, I do it quite frequently, actually. I use popliteal plexus as opposed to an IPAC block because, first of all, you need a lot of volume for the IPAC relative to of the popliteal plexus. The objective of popliteal plexus is that the posterior capsular innervation all come from the sciatic components, and they form a plexus that is periplexus. It's around the popliteal artery. So while the IPAC injection is close to the capsule and anterior or more distal to the artery, here you are just doing a perivascular injection after the femoral artery has exited the adductor hiatus at the distal part of the adductor canal. Mm-hmm. You just inject, we inject about 10 mils of 0.25% or even 0.2% in many times. And it seems to work, it seems to provide the analgesia we need for sciatic nerve related innervation. Now, there are very few published literature relating to that. I think the Scandinavian group actually described this by Dr. Benston and them, but they don't seem to have followed up with any randomized controlled trials. This is my comment.
Okay.
Okay. Thank you. I think that's all for now from the floor.
Okay, thank you, everybody. Thanks to Justin, Dr. Professor Ko, and Professor Sakura.
Yeah, I just realized that my volume is a little bit lower. I accidentally hit the button that reduced my volume. Sorry about that.
I think others have managed to increase their own volume, so that's fine, Shinichi, no problem with that. Thank you again for this wonderful presentations. We're going to have a short break, after which we will come back and have another potpourri of another few varieties about the hip joint. So don't go away. Just go and have your favorite beverage and be back in 15 minutes time.